So before I introduce Dr. Nwariaku, I want to give you my own comments about today. And I was saying to someone else that I kind of forget during the year how great this day is. And I think we all go through all the work that we do and have the demoralizing moments and feel burned out and concerned and worried about the future and wonder how we're doing. And a day like this changes that for me. I tell you that I'm on a high from listening to our residents, students, and seeing the quality of the work that they're doing and the privilege that we have to work together and to see these residents that are the future of surgery makes me very optimistic about the future of our profession, the future of our department, and any type of problems that I was having with wellness or feeling burned out, it's alleviated or definitely mitigated today when I just see the incredible intelligence, dedication, creativity of our faculty and our residents and what they're doing together. So thank you. You've made my day. And then I wish we could have it on different days because the other thing that makes my day is match day. And because I always am on a high when we have match day and thinking about the new residents that we're going to have joining our residency programs. So we get to combine it today. So it's almost like too much to have it all at once, but I guess I'll accept it because it's a great day. So I want to introduce Dr. Fiemu Nwariaku, who's our visiting professor, chair of surgery at the University of Utah. And I really consider Utah to be a sister program to ours. I think we have a lot of similarities. There's a few academic surgical programs that I think are similar to the University of Washington, and Utah is one of them. We share several things. One of the things is geography. We share geography in terms of a very large part of the United States that we cover. Dr. Nwariaku has been chair at Utah just a little less than 2 years. But before then, a long career at UT Southwestern. So Dr. Nwariaku was a resident at UT Southwestern. And I guess they liked him because they kept him on as an assistant professor, and he rose through the ranks, associate professor, full professor. But more than that, he became the vice chair of research, the director of a T32 grant on burn and trauma, director of NIH program project grant on injury and inflammation, associate dean for the Office of Global Health, executive vice chair of the Department of Surgery, and director of faculty development. I'd say that Dr. Nwariaku went from assistant professor and had a reasonably successful ascension at UT Southwestern. And he's also the past president of the Association for Academic Surgery as an example of his prestige and his reputation in the academic surgical community. We've been talking about science today, and Dr. Nwariaku is a serious surgeon scientist with grant funding throughout his career. He is well known in many areas of surgical science, in inflammation, injury, and endocrine surgery, global surgery. He's a world-renowned endocrine surgeon. So Dr. Udyavar has been hanging close and picking up tips from him, as one does when you're an endocrine surgeon. And I think maybe most importantly, it's clear that he's been a mentor to students, residents, faculty throughout his career. He's built clinical programs at UT Southwestern and now at the University of Utah. And as many of you know, we have a strong presence in global surgery in this department, and closely linked to global surgery is our rural surgery experience that we're expanding in Billings. And so I'm particularly pleased that Dr. Nwariaku is going to be speaking to us about academic health systems, a pillar for strengthening global health and reducing disease burden. Dr. Nwariaku, thank you.
Thank you, Dr. Wood. Is it too loud? Can you hear this?
Yeah.
You can hear that. Great. I'm trying not to, with all the lunch, that wonderful lunch, I don't want to stand here and fall asleep. So thank you for that kind invitation. As I say, that's a recommendation my mother would believe, and my father would wonder who you were talking about. But thank you. I can't. So as you heard from just now, I've seen a lot of these research days. I've listened to a lot of presentations, reviewed a lot of abstracts, and I'll have to say, what a delightful day. What a delightful day. I think this is, I wish I was in this department, having listened to what you have, but not just the creativity of the presentations, but the questions and the way that the trainees answer the questions, and the fact that there's all of you here who stay to the bitter end, as I call it. I used to run this conference in Dallas, and usually after lunch, there were more empty seats than seats full. So congratulations, Dr. Wood, on an outstanding day. I've long admired this Department of Surgery from when I was a resident, and today just further reinforces and shows me the true detail of what a really outstanding Department of Surgery. And for the trainees in the audience, it goes fast. So savor it, because 10, 20 years from now, you will wish you were a trainee again at a place like this with such rich, creative and supportive faculty. So congratulations. I wanted to, first of all, I got to change this. Victoria, is this? I wanted to, I thought hard about, what I would talk about today, and I ended up putting this topic, and I approach it with sort of great trepidation, because this Department of Surgery has had a long, rich, storied tradition with global surgery. I don't see Charlie Mock here, but he was one of my early mentors with Haile DeVos, when I was considering whether you could actually make this a meaningful scientific endeavor or not. So I sort of approach this with a little bit of trepidation, because I know I'm preaching to the choir here. But before I go on, you know, as is typical with these visiting lectures, we sometimes, I think, take for granted the investments that have been made before us and the foresight that these people have had in trying to invest in things, this academic mission we talk about. We had the good fortune in Dallas to have several endowed professorships, and I don't know how we could have done some of this work without that. So I have to recognize the Schilling family for allowing us to do this, because sometimes we forget that you can't always use clinical dollars to supplement an activity like this. So this is it's a big deal, and I'm deeply appreciative of the fact that you asked me to do this, especially when I consider the folks who have been here before me. These are icons of American surgery. These are my mentors, and I remember I can't even imagine my name on the same list with them, because these are such important people who've made great discoveries in surgery and who've done outstanding work over the years. So I'm really humbled to be asked to give this lecture with this group of people. I'd be remiss if I didn't mention the connections that I have here. It's wonderful to come and see old friends, but there's a connection with every single one of the people on there. And for the trainees in the audience who presented today, I'd say you're lucky because Dr. Mayer, he didn't say anything today, I noticed that, but I remember as a research resident presenting at the Trauma Society and the Shock Society, and once he stood up, I wanted to pass out. Because he would ask the hardest questions, but then he'll come after that and pat me on the back and say, good job. So, Dr. Mayer, it's a pleasure to see you again. I'm glad that you made it here. And Dr. Pellegrini, that you must look at this department with great pride. So thank you for all the work you've done here. I put Dr. Brackenridge up there because he was my resident, and I can't share the stories with you, but there are lots of them I can talk to you about later. So there's been I have a connection. I didn't even realize this, but two of my former mentees, Dr. Erica Bisgard and Virginia Wang up there, people who worked with me and did stuff with me. So it's just wonderful to come. It's like a homecoming for me. But the other thing that some of the younger folk may not know is the relationship between UT Southwestern and this department. And I'll just share it quickly, just in case you didn't know. So I arrived in Dallas to start my residency in January of 1991. And there was all this talk about an interim chair, and we're getting a new chair, and the new chair was going to come in June or something, and his name was Dr. Carrico. I said, well, fine. But the story is that in 1974, Dr. Shires was in Dallas at UT Southwestern and moved to this department with a number of faculty. And I'm sure Dr. Pellegrini and Ron Mayer remember that story very well. Shortly after that left, but he came with Dr. Carrico and some others, Dr. Heimbach and a number of other great surgeon scientists in the country. And Dr. Carrico had stayed on here as chief at Harborview, and then became chair and got re-recruited back to Dallas. So he was my chair for 7 years as a trainee, and another 4 or 5 as a faculty member, and actually passed eventually. He had a place in Woodby Island here, if you remember, and I think his final resting place is still there. So there's been a long connection between our institutions, or at least my past institution, which I still consider home. So what I'll do quickly today in about 40 minutes is just for folks who don't know, talk about how we ended up in this business of global health and global surgery. Talk about some of the drivers of the global burden of disease that is surgically related, and I'll share some insights about our Center for Global Surgery at the University of Utah. My only disclosure that some of the work I'm going to talk about is funded by these grants, which are now going into no-cost extension, so we're going to renew them soon. We're in the business of trying to renew them, but I have no other disclosures. It wouldn't be fair to talk about global surgery without me giving you a little bit about my story and why I didn't just wake up to start doing global surgery. It's been a part of my career for a long time. I went to medical school in that little district hospital in southern Nigeria. That's the hospital. This is a hospital run by the Southern Baptist Convention, which some of you may recognize as one of the largest Baptist conventions in the world. They used to be based out of Tennessee. I think they're based out of Fort Worth now. They bought land, built that hospital in the 40s. I finished medical school. I had more black hair then, and you could see. And I spent 3 years there doing a rotating internship, so OB, pediatrics, surgery, and medicine, and fell in love with surgery. I just could not do surgery. It was a really small hospital, very few resources, but plenty of surgery. C-sections, open reductions, thyroids, gastric procedures, bigotomy and anerectomies. How many of the residents have done a bigotomy recently? Raise your hand. 0. Yeah. Lots of wonderful operations. Wanted to train and went through the whole process and ended up matching as a prelim at UT Southwestern, and spent the last 3 decades there trying to, as I say, wait until something better came up, and then about 1.5 years ago moved to Utah. And we can talk about that story. But as you heard Dr. Wood, had lots of opportunities there. People often say, well, why did you stay so long? And I said, I did about 30 jobs in 10 years. So as you try to make decisions about what you're trying to do, it's helpful if you're able to grow in the same place. And I see lots of people here who have been here a while. And that usually helps you get some credibility. So anyway, I'll dive right into it and talk about sort of global surgery as we know it. So if you look at the work that has been done by the American College of Surgeons and faith-based organizations, global health has sort of been a hobby for most people. And global surgery is, as I call it, the redheaded stepchild of global health. Throughout the 80s, you know, all the oxygen was sucked out of the room from between HIV, tuberculosis, malaria. All the funding went with that. And talking about doing surgery in the framework of global health was just not considered until a number of papers came out, starting in about 2015. The Lancet published a number of series of papers, just trying to quantify what the global burden of disease was and how could you codify disease burden, talk about the same things you talk about today, access, disparities. And could we do something about these challenges that we, by the way, face here as well as in all those places? And they came up with a number of interesting things, which some of you may have seen. One is looking at the regions of the world, sort of where people didn't live a full life. So life expectancy was a big one. And if you look, and these maps are going to seem similar after a while. Most of the disease burden is in sub-Saharan Africa and in Southeast or South Asia. Just you can take this map and you can just replicate it for the next 10 slides. And I'll talk to you about why that may be the case. And so if you look at global surgery programs, many of them are focused in these countries if you're looking globally. So when they looked at, this is work that I think Dr. Zabas started, and when you look at what parts of this disease burden are surgically related, the summary is that most of it is really around injury and cancer. Those two conditions account for 90% of the surgical disease burden all over the world. Which, I mean, for me, that made it easy for me to decide where to focus, because sometimes you look at all this work and you can't figure out where you should focus your attention. So injury and cancer are the two biggest drivers of surgical burden of disease globally. This is a map from the World Health Organization projecting, you know, showing you the red and the blue, showing you that if you attack those two problems that surgically remediable global disease will be much less. I don't need to talk to you about injury. As a resident, you know, whenever I read a paper from Harborview, I went back to the lab to see if I could do something at Parkland that was similar. And usually by the time we figured it out, they'd done another one. But trauma is a big problem. And if you look at, I put this up here because, as I said, most of the funding in global health has gone to these three conditions. And thank God, so many of these, especially HIV/AIDS and now TB, less of an issue globally. But trauma has always outstripped the demand for care compared to those things. So the difference in the trauma that you see in low and middle income countries and the trauma we see here is that even though you have all the usual things, 5 million deaths, and for every death there's more people, the resources to recover those people into the society are less. The demand on the families who take care of those sick people take away from the economy of the home. So if a child gets burned, for instance, someone has to leave what they're doing and go take care of that child for the next several months, which means that they can't earn any income and the whole family suffers. And then most of them, if you look at motor vehicle collisions and deaths from them, the ratio here, I think, is probably 1 death per vehicle, and there it's more like 20 to 30 per vehicle because of mass transit. And then to add to that, you know, the capacity to manage them is not as good as it could be. So what are the people who looked at this have tried to figure out, well, why is this such a big deal in these countries? And this map summarizes some of that. just to tell, basically, the short answer is there's not enough surgeons, anesthesiologists, obstetricians, and pharmacists to take care of people. What this map shows on the vertical axis is the burden of disease. This is from the WHO. The burden of disease compared to the 6 regions that the WHO has. So South Asia, Africa, and East America account for a high burden of disease compared to the rest of the world, these high-income countries. They also have a smaller percentage of the global workforce in healthcare. So the number of, as I say, they call them SAOs, surgeons, anesthesia, and obstetrics. So that accounts for that. And then the size of these dots is the amount of health expenditure those countries or those regions spend on healthcare. So the bigger dot means that we spend more on healthcare. Those little dots on the left show that there's not as much expenditure. So if you combine the lack of a workforce with poor spending and a high burden of disease, it shouldn't surprise any of us that the outcomes are the way they are. And there are many people who are working on stuff like this. If you break down the regions, as I shared before, this is old, but it hasn't changed. This is WHO data as well, showing the countries with a critical workforce shortage. And they've narrowed that down to basically, I think Lancet has SAO as the thing, but this includes all these categories, doctors, nurses, midwives. Same map that you see, not enough. Those countries have a WHO critical shortage of the numbers in the place. This is an old map that I got when I went to, I'll show you the slides. We went to Sierra Leone in 2008 as part of Association of Academic Surgery course. And they had a 40-year-old civil war, ended in December. We got there in February, and there wasn't a single surgeon in the whole country. We went to do a course. We ended up doing surgery on the people, but this is, you can see Sierra Leone here has had basically number of surgeons per 100,000 population, and this is just the entire region in West Africa. East Africa is not much better. So the Lancet looked at this and basically quantified how many people we would need to get, what numbers we need to get to help with the workforce issue. And the red is that you need more than 19 providers per 100,000 population by 2030. The blues are the ones that are basically, you don't need to increase much at all. Again, you'll see that the need is mostly here and there. And there's all kinds of papers and things about what it takes to get there. How do you get there? Can you train doctors fast enough? Should you task shift and use nurses to do some of the things that surgeons do? What does it look like? So this is what, we talk about trauma and so on. This is what it looks like. You get a patient with a fracture that basically is allowed to hang out. They get a non-union. I did a lot of these before, and they need somebody to come back and do an X-ray, something to fix it. Pediatric burns are a huge problem for all the reasons you heard about at the talk yesterday. Cooking, explosions, and there's just not the capacity to manage this people. Here you can see this is way back before we started doing intraosseous resuscitation, but there's no IVs and then so this is someone's gonna have to take time away from everything else, take care of this kid for the next month, and they end up with that type of stuff. So you can just imagine what that does to the family. So that's just to give you a sense of what the burden of disease is. And if you look at surgery as just how much surgery is done in those places, this is what I think that was done a few years ago by a tools group when he was still at the Brigham, showing that, and you'll hear this a lot, worldwide there's about 5 billion people that don't have access to safe, affordable surgery, but the bulk of them are in the same area as they should. So the Lancet has tried to narrow these down into categories of, what are the things you can do, and I think this is where people begin to pick away at what components of this problem can you focus on as a department or academic center, and this is what they come to. These are the categories. So delivery, healthcare management is a big one. Most people who manage hospitals in these countries don't really have the experience or the training, so the resources are not allocated as well as they could. The actual nurses and doctors need, training and education. Information management is a big thing. In many places that I've been to, if you ask someone how many people die from a road traffic injury brought to the hospital, they don't know. Because there's paper charts, there's no audits, there are no reviews. So some of the work I'll show you is just trying to help them with getting some electronic mechanisms to begin to at least quantify the problem, because you can't begin to deal with it until you quantify it. And then you heard earlier about finance and economics and financial toxicity, even worse there than in many of the places we don't. So if you're interested in this business, this is what I call a target-rich environment. You can plug in. There's not a shortage of places where you can focus on, one component of this. Thankfully, the UN, since 2015, has actually, based on the work that a lot of people have done, has brought this up to the level of everyone else saying that surgery is a big part of global health. And as they deal with malaria and tuberculosis and HIV, there needs to be funding for surgery. So it's gone to that level, and it was included in this Sustainable Development Goals. These are one of the things that UN does every few years to say, we're going to look at these 10 things for the next 10 years. And so surgery has finally made it onto the list, and we'll see what happens with the funding for surgery. The Lancet also has begun to create things that can help people who are interested in this field to focus in different areas. And these are core surgical indicators published by the Lancet. So if you're working in a country, you can pick any one of these quality indicators as something to measure and to fix. A lot of people are using perioperative mortality for surgery as a big one. The target is that 80% of countries by 2020, which is passed, and 100% by 2030 should track POMRs and basically set national targets to begin to create interventions to address POMRs. But you can basically take any of those to do. And this problem is not going to go away. In fact, it's likely to get worse. So the Lancet published this a couple of years ago, looking at what the cancer burden is going to look like in these countries. And much of this is traditional colon cancer, breast cancer, esophageal cancer, prostate cancer. But the numbers are going to go up. The pace of the workforce is not going to keep up. So there's a need to sort of figure out creative ways to manage these problems. And there are a number of places around the country that are doing this. So what can we do? I mean, halfway through the day, I was apologizing to Dr. Wood because I spent the last 2 hours having a budget meeting on the phone with my CFO. So global surgery was not in my mind. But so what is it that we can do that can help bolster the capacity in these regions and begin to address the need that the patients have? I'll share a couple of examples that some of you may be aware of, some of you may not. But there's a lot that's been going on here, and I'm sure Dr. Pellegrini has seen this at the ATS in North America. But there's now a strong partnership between the Council of Surgeons of East Central Southern Africa, it's called COSECTA, the West African College of Surgeons, the AAS, and the Society of University Surgeons as a partnership. I'll share some of those details. But the goal is not to take boondoggle trips to far-reaching places in the world, but is to figure out how to use the systems that we've developed to help them develop their own systems, to ask their own questions and answer their own questions and build their own systems that work with them. This is all of that. I can't believe how all this is. When I was president of the AAS, this course, which I hope that all the residents who presented today will go to at some point. If they don't, please ask Dr. Wood. You should go. It's a wonderful course. It teaches the fundamentals of surgical research and career development, but more importantly, it exposes you to a cohort of your peers. And those peers become lifelong friends because you all complain about your failed experiments for years. You see each other at your meetings. I went to that and really changed the way I thought about research as a resident. But anyway, we decided we were gonna, it's done right now, I think it's done just before the February ASC meeting. But I thought this is when they say, I had a strong back and a weak mind. I decided I was going to do this in Sub-Saharan Africa, and we picked a country of Sierra Leone at the time, which was just a real tough time. We landed there in this old Russian helicopter with no windows and no doors in the middle of the night. And that's everybody sitting down. We'll strap your luggage down after we went to war. But we did complete the course with a group of folks from around the country here. But the next year, the AS Council approved that we went to Nigeria to do the same thing. But the fun part of it is that now this course is taught as part of the curriculum of the West African College of Surgeons by 100% local faculty there. None of us needs to go back there. It's been taught now, all the red dots are all the places where that course has been taught, and it's been modified for each region. And the fun part, I just came from the West African College meeting in Sierra Leone, and many of the people who took that course, whatever, 15 years ago, are now in leadership in their respective institutions. So these are people who now recognize that they need to invest in their people. For me, that's the value of a program like that. And of course, it spurred a number of academic, there's an association for academic global surgery, there's trainees and faculty who now begin to look at this from a scientific standpoint, and that's just been fun to watch. The other partnership that I wanted to share is this American College of Surgeons partnership with a surgical training hub in Ethiopia. ACS Hope, which is what you see here, used to be called Operation Giving Back, for those of you who are old enough. It was a place for retiring or more advanced surgeons to go and give back and do medical missions. And it's transformed now to a way to help some of these countries build their own capacity. So the ACS has donated an amazing amount of resources, all the quality, the Red Book, the trauma programs, and so on and so forth. And so that's in a partnership with a hospital in Ethiopia now, and Dr. Burma Tafara, who's a vascular surgeon in Wisconsin, runs this program. We participated when I was in Dallas. We actually sent a faculty member and a couple of residents to go for between 2 weeks and 2 months. And this is from Burma, by the way. There have been 13 academic medical centers. This was a couple of years ago. And you can see the faculty and the residents from all over the country here. But the important thing is that they've started doing research. They do quality work now of their own patients. There's a skills training center that people do from here, simulation center. They put the trauma database together. They now have an M&M, and they have a telehealth remote ICU for surgical ICU rounds, coaching, and tumor board. And this is Burma in Hawassa, making rounds on the telehealth equipment that was done, and they've written a number of papers since then. So that is one place where I think, without having to leave your own office, you can make a contribution. So what are the paradigms? I think I mentioned some of these. I think our special place in this space is to do what we do best: education and research and training. I mean, that's what we do best. And I used to do a lot of medical missions. I don't do much surgery overseas anymore because I think, as I tell them, they can do surgery better than I can on their patients. But what I can do is I can take the systems that we built here, that I've learned here, and try to help them develop their own systems so that they can continue to do what we do. So what does such a program look like? I think everyone knows this. The pieces I'll share with you if you're interested in this is that your local partners have to be credible. Many have seen some of these fail because there's no trust. Collaboration is important. And these last two things are important to me. If you're going to be doing the work, you need to be publishing about the work, and your partners, they have to understand that. Otherwise, it doesn't contribute much to some of the successes that you see here. Don't have to go through that. So I'll talk in the last few minutes about, what one of the things that attracted me to Utah is the Center for Global Surgery, and I'll share a little bit about that. This is the vision for the center. We have probably more sites than I would prefer to have, but there's such organic interest in doing this that it's hard to bridle that passion that people have. But we're in a number of places across the world. And every single one of our faculty divisions is invested in some training or research program in one of these places. So it's something that I'm actually very proud of, and I'm hoping we can find the funding to sustain it over the long term, because that's the biggest challenge with programs like this. The center has a myriad of collaborations, both in Salt Lake City. So at the University of Utah, we collaborate with the business school, the engineering school, pharmacy, dentist, nursing, and across we have all these partners. And I'll show you some of the work that's going on there. This is just the Center for Global Health Faculty. You may recognize some of them. These two individuals here are actually University of Utah faculty, but they're based in Ghana. And so they live there, they work there, but they have adjunct appointments at University of Utah. And these are all the faculty who are involved in some fashion. So what do the programs look like? I'll just quickly run through a couple of them. Dr. Rockwell, Brad Rockwell, is a plastic surgeon department who's been going to Ghana for about 13 years. He set up the only fellowship for hand surgery in Ghana and has been going periodically. And as of this year, and this is his local partner, plastic surgeon. As of this year, they graduated their first fully trained African hand fellow. And that two of them, and they both got traveling fellowships from the Plastic Surgery Hand Society, that travel centers around the US, and they came by and visited for a couple of weeks. And they're going back now to begin to build out that program. So Brad's getting ready to retire, but I would suspect that in a couple of years, they won't need him anymore because they'll have their own fully trained hand surgery fellowship. And they published about this. They talk about how you start it, how you sustain it, you know, and so it's just been a wonderful thing to see that development. And as I say, the measure of success is that we don't have to go there again after 20 years. Jerry Myers is my division chief for urology. Apparently in Rwanda and Kigali, they've got a lot of lower urinary tract disease, and but very little. There's no reconstructive urologists in the region. Got to go down to South Africa to find one. So he and Catherine DeVries, who's someone they started this IDU, they started a program to train local surgeons in reconstructive urology. So there's a lot of basic general surgery training in these countries. There's not a lot of specialty training. It doesn't matter what specialty it is. Pediatric surgery, plastic surgery, breast surgery. So the goal is to try and build that cohort so that they can take care of the patients. The other one I'll mention, Liam is a colorectal surgeon with us. He's been collaborating with Gifty, who's in Michigan, and Jonathan Larry, who's at UAMS in Arkansas, Little Rock. And they're just starting the beginnings of a colorectal fellowship in Ghana with the Ghana Society of Physicians and Surgeons. In fact, I just met last week. And the goal is to build their faculty and then begin to train people in colorectal surgery. And then Kirsten Brown, I think I mentioned this earlier, who's a breast surgeon who's been starting some work in Mongolia. So Ray Price, who you may be aware of, has worked for 20 years building out laparoscopic surgery in Mongolia, and that's fully self-sufficient. Laparoscopy is now widespread across Mongolia, and Kirsten is building on his platform to create. They're starting off with breast cancer fellowship, but the goal is to create a comprehensive breast cancer screening, prevention, treatment program in Mongolia. So this just started. They just published, I think, a few weeks ago, their first project was to basically set up a breast cancer database, just so that they understand what the burden of breast cancer is in the country, because they didn't. So those are just some examples. One of my faculty, Sula Jaraman, who's, I'll show you some of her work, recently collaborated with the ACS, started a new global surgery fellowship in partnership with VCU and the American College of Surgeons. So we split the salary 3 ways, and we get a fellow every other year. 1 year it's a VCU fellow, one year it's a Utah fellow. They spend time at the college, and then they go to Hawassa to spend time working with the physicians there. And then through that program, they've begun to work with SurgeHub, which is the other, is a UN program that teaches surgery through a program online that's sort of self-paced and asynchronous. So we're contributing to SurgeHub now. That's something that you could do here. Is you have a platform for sharing techniques and so on. So I'll talk about some of the work that Suda is doing in Rwanda. This is just a map of Rwanda, and Suda has been working with them on emergency medical service capacity. So she's a trauma surgeon, and she's been with us for a while now. And she's looking at this pre-hospital time. This is what we're all familiar with. You get a call to emergency medical services, ambulance is deployed, they pick you up, get you to the facility and behind you up. And if you look at what's happening in Rwanda, it's the complete opposite. There's no dispatch center. It's all done by phone. There's no location data. There's no electronic data. And so she wanted to see if she could streamline this and make it more efficient. So she wrote this grant. This is one of those I forget what it was, R33 bar 00 or something. But this is her second year doing that. What she did was she applied a technology component to this to create a server and an application. And basically what that does is it reduces the number of calls so that once the incident gets called in, it gets sent to the server, and the server basically notifies everybody about where the location is, what the details are, and that way everyone's prepared to do this. And she recently had a second round of funding with these two European groups to basically improve the platform. So they've designed the platform, the design that you can see the locals piloting it there. But the next question is, once you hear about the victim and how do you prepare the hospital and how do you get the hospital to get the patient close to the hospital, the closest hospital, and how do you make sure that they're adequately resourced to take care of the patient. So that's the second phase of the project. In parallel, when I was in Dallas, I started this project in Dallas, had a similar R21, not knowing about her work until we got together. But, we did this work in Lagos State, which is a state of about 22 million people in southern Nigeria, one of the most densely populated pieces of land on earth. Big trauma problem, but they collected their trauma data with these sheets. This is what the ambulance people took to the scene. This is what they because of traffic, they had to put these ambulance points all over the state, but without much information. They just picked up a place and decided we're going to put it in. So we said, well, what's the burden of trauma? What's the burden of injury or traffic injury? They couldn't tell. But they had about 36,000 of these sheets. So I got one of my medical students. And basically paid for a little red cap electronic data capture system that we designed off this form. And we started collecting data. So we actually ended up putting about 18,000 of that into the red cap server, but so that gave you a baseline. And then just to understand where this happened, I had the engineers at UT Dallas design me off Google Maps, a road network map of Lagos. These are the small streets, these are the major freeways. And then I talked to the Ministry of Health to say, how many hospitals do they have? 36 state-owned hospitals. So I asked my other research assistant to go to Lagos and geocode each one of these hospitals. We bought a little machine, $10,000 GPS, fancy GPS, and she went and she geocoded each one of those hospitals. And so the engineers now basically taking the top hotspots for where injuries occurred, mapping them to where the state hospitals were, and trying to figure out an algorithm that would guide the ambulance people to the best places. But what was I thought really cool about it was that you could tell based on the time of the day of the week, the time of the year, which places were likely to have a high incidence of. So that was fun. She got a couple of publications out of it here, and it was funded mostly through the R21 and in the process of trying to figure out how we're going to deploy it at scale. This was just one state, 30 hospital but we're thinking about doing a national survey. I mean, this was just before Colby, so we had to put a stop on it. And then we were fortunate enough to get another grant from the NIH. This is like a T32, but it's an international training grant. It's called a D43. And it's supposed to help you build research capacity, just like we do here for the residents and fellows and faculty. We got that funded. I ended up with I wrote it out of what we do here in Nigeria because they have the highest injury burden from road traffic. And these are some of the folks who, scholars who we accepted into the program. The goal is for them to use the program so they did didactic, they did online, or for them to write their own grants. So they've all graduated except for Tina here, who I just talked to. And basically, I would say I'd give us a C. I'm not sure it's an A. I think it's a C. Yeah. But some of that was COVID, so I can't be too critical. But many of them have advanced in their institutions. They've presented, they've published. They applied for these two K43 grants, which are the international version of a K08 or K23. And they're still working on them, and they're co-investigators on some other grants. So moderately successful, but I think we could really do a lot more than that. It's a wonderful mechanism, but it's really tough to get from the NIH. So I think that I hope that I've convinced you that there's hope. So how do you engage as an academic health system in the middle of all this other stuff we're doing? We're trying to train you, we're trying to get funds from the hospital. I think that there's a lot that you can do here in global surgery. I think you can, my sense, the two things I focus on are developing metrics, collecting data, because many of these places just have no data collection mechanisms. And I'm very interested in using data science to solve some of these problems. And we've just written some grants using our data science core in Salt Lake City. And I think that, you know, if we keep at it long enough with the right partners, we should be able to make some headway into some of these diseases. So I'll stop there. I hope I've convinced you that global surgery is a real thing. You can actually make an academic career out of it, even though I haven't. And there's a need if you're interested. You don't have to go to dangerous places to do this work. So I'll stop there, and I hope we can have a little conversation before the time is over. I thank you for your attention. It's been a wonderful time. Thank you.
Caitlin and I are going to be handing out microphones if anybody would like to come forward and ask questions.
Yeah, I was waiting for Dr. Stewart to get up, but just before he does, you know, I think you are preaching to the choir here. We've got so many individuals that are interested also in global surgery, and the environment, like the environment that you see here in research, the academic environment, the point that you've made, you know, is the environment that fosters the interest in doing something more than the day-to-day clinical care that we do, and involvement be kind of beyond the walls of our institutions. And we have a lot of people involved in Rwanda here, but Barclay's been leading our global surgery effort, and I thought you'd have some comments about what we do or questions for Dr. Nwariaku.
Yeah, thanks so much for being here. It really is an honor to have you. And certainly you've left footsteps for many of us to follow. Just reflecting on your comments about all the capacity building that's needed and how much money it costs, and countries not having the domestic funds to mobilize early to make some of these huge investments in surgical care and really move the needle on the burdens of trauma and cancer particularly. A lot of this money comes internationally through other global health authorities, like you mentioned, through mega donors like the United States, the Gates Foundation, and PATH, based here in Seattle, and certainly UNAIDS, USAID, and others. They go through these channels that have historically used infectious disease specialists from academic departments to really guide how money should be spent to improve the health of the global population. And we haven't been at the table as surgeons for a very long time. What do you think, or any good examples, or what do you envision for academic departments trying to promote having technocrats as surgeons in these channels to help improve how funds are spent internationally to improve global health?
Yeah, thanks for your question. I think it's an important one, because you are right. The funding that went to communicable diseases for 2 decades or 3 decades was primarily driven by decision makers who were, pediatricians and community people who were at the table, and we really were not at the table up until recently. So the first thing is, I think that some of our organizations need to be more active in partnering with the USAIDs and the people like that. And the CUGH is a good place that I've been to, a consortium of universities in global health. They eventually had a surgery section after a decade. Okay, but that's a place where you can sit next to a country director for a USAID and express what you're just saying, which and most of the time they're like, oh, I didn't know that. I didn't think surgery was the thing. Dr. DeBas and the UCSF folks did some really wonderful work about how much more cost effective it was to have a functioning district hospital that did hernias, gallbladders, and appies on the community compared to vaccinations for measles. And it wasn't much different. So, but the folks there, the folks in these agencies haven't heard that before. So I think serving on those committees, saying yes to when you get called to go to those meetings is one way of doing it, because otherwise no one else will. The other thing I'll say, and this is a personal thing of mine, is I really think that we need to wean ourselves off the aid from these agencies. I think that so many of these countries, believe it or not, are now coming into their own economically. I mean, you Google, Toyota and Tesla and Kia have massive manufacturing plants in Ghana, which and they sell cars. Some of the new places that have discovered oil and minerals and diamonds have economies that are getting better, and they're trying to invest in health. So my challenge to these people, and the work we did in Lagos was interesting, because they asked, well, what money are you bringing? I said, we don't have any money. I said, but I can take your budget that you use for your 36 ambulances, and I can help you deploy more effectively than you're doing now. And they bought it. But I think that we need to begin to hold these governments accountable for the health, because they spend the money already. I mean, these folks spend a lot of money and a lot of things that don't make sense because they're not data driven. So it's 2 parts. One is, yes, we need to continue giving aid, but eventually, if you keep giving that aid, they'll never get out of this thing. So helping build a capacity about how do you manage your resources more effectively. I think the ACS just started, they want to do a leadership program that we're involved with the West African College of Surgeons, bringing the leaders here as part of the ACS leadership course for healthcare, so that how do you run a hospital when you have a budget of, whatever it is, where do you put it? And that's where people like you, when you start a project there, they can say, oh, if you succeeded here, perhaps we can fund get you a couple of nurses and a database and so on and so forth. So those are my thoughts about how we might be able to be successful there.
Thank you again.
Thanks.
For Bridger.
Thank you so much for your presentation and for being here for the past several days. Do you have recommended models for how academic centers can support global surgery work from a financial standpoint? I think a lot of the traditional models, such as through research grants, may not support the needs and priorities of local collaborators in many of these countries. And despite the growing interest of trainees and faculty in doing this work, financially, the bottom line is it can be difficult to support it. Models I've seen are private donors, and I think that has been a great way for the Boston-based programs to support this, but finding the Carmela Pletchians and Tom Whites of the world can do this.
Yes, they can. But you bring up the sort of the Achilles heel of global surgery is how do you sustain it financially? And I don't know how, but my plan is to cobble together what I can and not use clinical dollars from the department to support it. I actually, when I go to Salt Lake, we hired a advancement director, because in this business, when you try to raise money as a department, you're beholden to the institution most of the time. I don't know how it works here. And so, they're trying to build a new cardiovascular tower, no offense, but no one's going to listen to you if you're trying to build another program. So we had to basically pay someone to be embedded in the advancement office, but their primary responsibility was to raise funds for the Department of Surgery for a variety of priorities, including global surgery. And if we can get enough to provide some seed grants, support the faculty who want to do the research and get them funded, then the burden is not as high because, then you don't have to support, an entire FTE because someone wants to go somewhere else. So I think between the advancement in Salt Lake City, I'll tell you what I told the story yesterday. I went to Cambodia last year because, and it's a long ways, because the LDS Church had given us some money to build laparoscopy there. But the money was given really to provide equipment and train some people, but it wasn't enough. So I had to make the trip so I could go have that conversation about why this amount of money needed to be stretched out for 5 years and why they need to triple it. Because if we can get the whole package, then within that period, we could get some people to write some grants. It gives you that runway, whether faculty or trainees, and then we can begin to build up. But that's sort of how I've done it. We still pay for some as a department, but my hope is to wean the Center for Global Surgery off some of that clinical money. Cool.
Jeffrey, with plastic surgery, I really enjoyed your talk and it really resonated. Having dipped one or two toes on the global outreach work, my view is it seems there's a lot of effort around the US, sometimes with small shops based at a single university or multi-institutional consortiums, some of which are doing work with multiple institutions in the US or groups in the US doing work with the same center in another country, but the right hand and the left hand don't really know what they're doing. So you talk about maximization of resources in those other countries. To what degree do we need to maximize our own resources and capacity here in the US? I mean, obviously these efforts are not going to get nationalized by the US government, but to what degree can we improve our resource sharing here in the US for this type of outreach?
Super important. And I mean, just to give you an example, I think several years ago, we went to a meeting in Liberia as part of the West African College of Surgeons. And they always have an outreach thing where you go to a rural hospital and you operate. And a number of friends of mine from around the country here, we were going to do surgery. We got there was a Swedish anesthesia team, a British ICU nurse team, and then us from the US. And no one knew who was there. And we operated, and it wasn't, let me just say, it wasn't the most efficient system that I've seen. But to your point, the programs like the ACS Hope program and programs that bring different groups together, I've found to be the most effective because they know what the need is. And they can give you a menu as a department and say, we need a plastic surgeon, in 2 weeks, we need them for 5 weeks. And there's going to be a resident from, Stanford or somewhere. And this is the team that's going to be there. Because it's really hard to coordinate if you don't have a central repository of people, problems, and data. So to me, I think that is the model I would love to see. And we're lucky that we have the college and they're strong supporters in the college that want this to happen. So that would be, I'm going to hang my hat on that one.
And which?
Yeah, I was going to comment on that one also because what Dr. Nwariaku said about ACS Hope. So Dr. Oyatunji and I have been working in Rwanda on the cardiac surgery, and there's been a program there, Team Heart, that's been going there for 15 years in an effort to, well, first outreach mission-based trips with an intent of creating self-sufficient capacity, but never really moved. But we found there are teams from France, from Nova Scotia, from Belgium, all also going to Rwanda, and none of them connecting with each other. And what ACS Hope has been able to do is actually bring all of those programs under one umbrella, meaning all the programs are independent. But we've developed calendars and strategy that is combined amongst those disparate groups from different countries that is now under the coordination of ACS Hope that's now moved the needle to actually, we're at the threshold of independent cardiac surgery in Rwanda. But that's required exactly what you're talking about.
Do you think the ACS has the desire and or the capacity to do that, globally with coordinate at least from the US, all the surgical outreach throughout the globe, or is that kind of beyond there?
Well, I don't know. This is a short answer, but I'll hazard a guess that no, probably not. But I don't know that they need to do it all over the world either. I think that if the COSEXA, this hub in Hawassa, for instance, if they can get that to work, it's one hospital in one place in a region. All the other countries, the 14 countries that have surgeons, needs for specialist surgeons come there. And then they go back to their countries and hopefully they will develop their own programs and the ACS doesn't have to deal with that. So Gurma's point is that we want to have regional hubs, an East African hub, a West African hub, a South Asian hub. And then they can now, attract it's almost like regionalizing training and education for specialists, because that's what the need is. And that maybe the ACS has bandwidth for, but I don't see them going all over the world doing this. I don't know what your thoughts are.
Well, specifically, ACS Hope said we're going to do 3 places. So Hawassa in Ethiopia, Kigali in Rwanda, and Zambia. In an effort, and each of them are different in terms of kind of what the focus is, but to gain some experience that could create, the experience to be able to have a ripple effect with other ACS programs, but with independent programs that are based locally. Dr. Oyatunji.
Thank you very much for spending the last couple of days with us, Dr. Nwariaku. I grapple a lot with the issue of global surgery because primarily from the brain drain portion of it, because I know that my existence here, my presence here is contributing to part of that brain drain. But my question for you is, how do we make a case for the bilateral exchange of knowledge? So we focus a lot on what we can do for like in local and low and middle income countries. And I remember in 2016, I went to Addis Ababa with Dr. Reich and Dr. Buschlager, and I came back with, there are actually simulators that we developed together with them that were more realistic than what we were using here. And we used Tom Varghese chest tube simulation, but we modified it for the local resources. And I said, it would be so amazing if we made it a portion of our training. There's so much we can learn from these countries, but we focus a lot on what they can learn from us. And I know in developing their programs, right? I still think that in the training paradigm, we need to find a way to make this a bilateral, long-lasting relationship instead of waiting until we can contribute as attendings. So what are your thoughts on incorporating global surgery in the training of our residents?
Well, yes, I think we should incorporate it, but I don't think it's just for the residents. I, as a faculty member who's been in practice for a long time, still learn from these relationships. So I think, yes, we should have a curriculum, and AAGS is working on one. But I think for people like you who are established faculty, even on the research side. So I'll give you an example. Peter Kingham, who's at Memorial, actually, I met him at that meeting in Sierra Leone as a medical student. He went there to start a residency. Has developed a relationship with a group in Nigeria where they set up a whole colorectal colon cancer program. And now they are actually studying simple things like, screening colonoscopy in that resource setting, they're getting tissues for, and I'm not saying that's the only thing, but they're getting tissues from colon cancer. They're finding differences in both the incidence, the prevalence, and the genetic pieces of colon cancer in New York and there. And some people do it for prostate cancer. So there's a lot we can learn. The reason I think there's so much focus on what we can give now is that the infrastructure to collect the data and analyze the data and make plans hasn't existed in many of these places for a long time. So my hope is that once we get past this hurdle of where you can walk into an office and say, okay, this is how many patients we had last year with this disease, and this is the, just like you heard presented, then I think we can begin to look at this more sophisticated things about, what can we learn about the disease bidirectionally, but absolutely needs to be bidirectional, and it should. No one asked me about local. I always get a question about, what about Northern Utah?
What about Northern Utah?
No. The other point I didn't make as clearly is that the other piece about learning, Laura, is that there are communities in our own community that have specific needs in healthcare that we ought to incorporate into this, and we're doing some of this. So, unlike we have, apart from the indigenous populations, we have Utah has a lot of refugee populations. Dallas did too. We had I think around where the hospital was, we had one of the biggest Hmong populations in the country, with just a totally different approach coming to the hospital. So what we're trying to do is take some of the things that we learned from those places and apply to how we do things with access, with culture, with language, for our own communities here. So I think if you're going to do this, it's important that you don't lose sight of what's in front of your nose, as we say, because it's helpful to also address these health needs locally, because otherwise they come back and bite you, because if they don't, if your population doesn't have access and they only come to the ER, you're going to pay for it as a health system at some point. So that's about Utah. Thank you for the question. Great question.
Well, and I think, we've mentioned it, but Dana Lynch is our program director for our rural surgery program. And we've purposely said the rural surgery and global surgery aspects of our program are closely linked. And we now have this relationship with Billings, that our vision for that is a rural surgery track within our residency program. We have a residency program like yours that's known for our academics, for what we saw here today. But like you, I feel that we also have a responsibility to our region, and our region needs rural surgeons. They need surgeons in critical access hospitals in Nome or in Libby, Montana. And we're the teaching sites that are in that region. So we ought to simultaneously, while we're creating high-powered academic hepatobiliary or transplant surgeons, should be also developing rural and global surgeons.
Yeah, well, I'll tell you, I have at least one resident every year who asks me about what happened to the rural track. And so I'm working with the program director now to try and reinstate it, but it'd be wonderful to collaborate with you for that reason alone, to develop a track for our residents who can go out to some of these communities and begin to learn stuff.
That might be something we can work on together.
Absolutely.
Any other questions for Dr. Nwariaku? I want to thank you so much. We have a certificate up here. Oh, another one, yeah. Certificate for you.
Thank you.